Good morning.
Good morning, everyone. So we're going to go ahead and start. So I want to welcome everyone to our March Provider Forum. And we're going to discuss bipolar disease and the associated behaviors. We have Nanette Wrobel on, and I believe Mark is going to do the introductions.
Yes, good morning, everyone. This is Mark Altholtz. I'm the Chief Sales Officer for Tarrytown Expo Care Pharmacy, and it is a great pleasure to be with you today. Dina, thank you for the opportunity for our pharmacy to present today's education. Many of you might be saying, who is Tarrytown Expo Care Pharmacy? Where is Tarrytown? So I thought I'd take a moment and just provide a quick introduction of who we are as a pharmacy. First off, we are an IDD and behavioral health only pharmacy. So that's all we do. Our company started 17 years ago in the Tarrytown neighborhood of Austin, Texas. Today, we've grown to operate 11 pharmacies across the country, one of which is now in Tampa, Florida. And we offer services throughout the state of Florida. And we are, as I said, 100% focused on IDD and behavioral health. We've grown from what was 150 individuals served in 2007, 17 years ago, to today we're over 30,000 individuals serviced in 31 states. We are super excited to be with you, not just because we're excited to present this education, but we're excited to expand our national partnership with the ARCs. We service the ARCs currently in 6 states. We're a national sponsor. We attended the national convention this year in Columbus, Ohio. Dina was there with us. She actually has a great picture of herself and Chris in front of the Welcome to Columbus sign, which promoted the ARC conference. So we're literally servicing thousands of individuals at ARC locations across the country. Look forward to speaking with you more about it. Today's session covers behaviors associated with bipolar disease and their treatment. And your speaker, Nanette Wrobel, many of you, I'm sure, are familiar with her. Those that aren't, Nanette is a pharmacist. She's been a pharmacist for 40 years, again, exclusively within the IDD space. She is a national thought leader for IDD. She speaks for industry across the country. She's also a member of our business development team with myself and Chris Asaro. Chris is a pharmacist and he handles business development for us in Florida. So I've had the pleasure of hearing Nanette speak often. And every time I've heard her speak, I've learned something new. Part of her gift is that she's able to take what are sometimes complicated topics and really make them reasonably simple. And she's also pretty funny. So you are in for a treat. And I wish you a great session today and look forward to Nanette's presentation. So thank you all for the opportunity. I turn it over to Nanette.
Thank you, Mark, and thank you, Dina. And one of the things that Mark didn't mention is that we are very committed to education in this field. And I think that many of you out there would agree that we can never get enough education. We don't have a lot of published material about our populations, so we have to learn from one another. So this is really what we do besides some of our webinars that we do monthly. We do these kinds of webinars for associations, we do symposiums, we do meal programs. So please, any opportunity that you might have to join us, we would definitely welcome you. It's always a learning experience, not only for you, I hope, but also for us as well. So today we're going to talk about bipolar disease, and I think this is an important topic because we do have a number of our individuals who quite honestly suffer from this disease state, and sometimes it's difficult to recognize some of their symptoms. They may look a little different than the normal intellect population. Many of them also may be nonverbal, so they can't walk up to you and tell you that they're having some challenges. But for whatever reason, we're going to go through today some of the ways that we can identify this disease state and maybe help our individuals. So first, what is bipolar disease? So bipolar disease, by definition, is a disease in which we experience both manic phases and depressive phases. Typically, the manic phases are shorter, although they can last up to 19 weeks. They are shorter than the depressive phases. But the regularity of the ups and downs, so manic plus depressive phases, is really defined by bipolar 1. So that's the classic kind of bipolar disease that we think about. Bipolar 2 is a softer form of that disease. So maybe not as high highs, maybe not as low lows. And then cyclothymic is just an underlying type of almost depression with very few manic symptoms associated. When we look at why treatment is important, one of the things that we look at is the fact that this is a lifelong condition. So many of our individuals may have been diagnosed at young ages, maybe as a teenager, maybe in their early 20s. And this is a disease that they will carry throughout their lifetime. And one of the things that we do know for all of us, whether we have a diagnosis of bipolar disease or not, is that the quality of life issue is important to all of us, and mood stabilization helps with that quality of life. And then what is some of the consequences of improper treatment? Is we prolong the disease and we prolong the pain associated with that disease because of some of the harmful behaviors that may take place with our individuals. Now, when we look at the lifetime prevalence, one of the things that we look at is how many people that we serve might have bipolar disease. And it's really both combining bipolar 1 and bipolar 2 is about 2 to 3% of the population. However, the real discussion is this actual incidence much higher based on individuals who may be self-medicating, or is it based on misdiagnosis? And one of the things that we do know is that it may take up to 10 years to be diagnosed. So it's a long period of time before some individuals actually reach that diagnosis. The recurrence rates are greater than about 90%. So just because you might have one episode, the expectation is absolutely that you're going to continue to have episodes throughout your lifetime. So prognosis really is about the number of episodes and the severity. So one of the things that we do know is delaying treatment can have a negative impact on the progress of this disease because it will make the episodes either longer in time or much more severe than they need to be. Now, unfortunately, when we talk about epidemiology, we also have to face the fact that this is a disease where all of us have heard about people in the, people that we serve, maybe, but also others out there who have attempted suicide. In fact, the suicide attempt is about 25% of patients, about 15% completing it. And you may have heard of, TV stars or movie stars or, chefs out there, all sorts of people who have unfortunately died of this disease state. Now, one of the things that we can do when we look at this disease is, can we blame somebody for it? Well, yes, we can. We're going to get to that in a moment. But when we look at the epidemiology and we look at other comorbidities, what else do we see going on? So certainly substance abuse is one of them. The use of alcohol, the use of drugs to try and mute the manic or the depressive phases. Sexual and dangerous other behaviors, spending sprees, gamblings. We've all heard of this going on. Maybe not with our individuals, but certainly we're going to define some of the ways that we can identify their features as well. And then this is almost a leading cause of disability. So bipolar disorder is costly in terms of not only the billions of dollars spent, but the emotional costs to not only the individuals themselves, but to family members, to those that work with our individuals, to others in their group home or their ICF, society at large. Everybody seems to be involved in trying to manage an individual with bipolar disease. So what are we talking about? Why does this occur? Well, to the right, you see a picture of lots of our, neuron pathways in our brain, and it does come to brain chemistry. So what we know is that there is a dysfunction in some of the three major brain chemicals, norepinephrine, serotonin, and dopamine, Those three receptors are responsible for how we feel on a daily basis, how we take in our environment, how we lay down memories. It also involves in our ability to walk and talk and move about. And then our GABA neurotransmitter is a calmative agent. And so if there is a dysfunction in the ability of our brain to be calmed down because we don't have enough GABA, that's where we can see the explosion of the manic phase. So it also involves a deregulation in a couple of other hormones. So our adrenal hormones, our thyroid hormones, our growth hormones, and then unfortunately, also abnormalities in our sleep cycle. So in the regulation of our circadian rhythm, in which we all have, the ability to fall asleep at night, the ability to wake up in the morning may also be disruptive. So one of the things that you're now thinking of is all this brain chemistry is working against that individual, and we need to calm that brain down, and you are exactly correct. When we look at the characteristic symptoms of the manic phase of bipolar disease, we think about abnormally and persistently elevated, irritable, or an expansive mood lasting greater than 1 week. In our individuals, that irritability is something that we over and over have notations about. And then in addition, the presence of 3 or more of the following. So do they have an inflated self-esteem? Do they think they can do things that maybe they can't? One of the classic signs and symptoms of the manic phase is the decreased need for sleep. And while some of us may think, oh, well, that's great, I can get along on 3 or 4 hours of sleep, we know the consequence of the lack of sleep. You know that your sleep patterns dictate not only how you're going to feel, but also it helps the brain heal from whatever trauma it may have had the day before, intrusive thoughts, all kinds of things going on. So that's an important part is sleep. And then individuals become more talkative than normal, or they have this need to continue to talk. So some of the nurses, some of our caregivers may say to us, John out here doesn't seem to stop talking. He is always here. He is always in my face. He is always concerned about everything. That flight of ideas is something, or those racing thoughts moving from one topic to the next is also something that we see, along with easy distractibility. So this may be an individual who quite honestly can no longer function in a situation where they are at a workshop or a work program. They're easily distracted. They go from one thing to another. They have increased goal-oriented activity. So maybe more activity or even less. We even see people that kind of stymie and they cannot function physically any longer. And then excessive involvement in pleasurable activities that may have a high potential for painful consequences. So really, it's as if the frontal lobe of our brains, which dictate to us how we act on our thoughts, may not be functioning well. Characteristics, again, mood disturbance is sufficiently severe to cause marked impairment in either a work or a social function. Maybe usual social activities that our client enjoys are no longer there, or in relationships with others. They may cause the need for hospitalization, which of course we try to avoid as much as possible. And then they may even have psychotic features to their manic phase of bipolar disease. And it doesn't happen with everyone. So I'm not here to say that the psychotic features are a feature that we see all the time, but we have to be on guard for them as well. And then the symptoms should be evaluated to make sure we're not treating bipolar disease when some other medical condition is occurring, either substance abuse or mania, which we can see secondary to antidepressant therapy. So somebody, for instance, who has started too quickly or too high of a dose on an antidepressant, we can throw them into mania. And then also things like steroid usage, which may seem benign, but I will tell you from a personal standpoint, my mom and dad went to Hawaii a number of years back for a vacation, and my mother is a nurse, but she actually had to quit nursing because she became very, very sensitive to the chemicals used in the soaps and in cleansing agents that the nurses, of course, are using constantly. So because of that, her hands and her arms broke out. She actually had to quit nursing. Now, she did go on to another passion, so that's great. But here she is in Hawaii, already is set up with sensitive skin. And of course, we know Hawaii, what are you going to do? You're going to be out in the sunshine. So she was. and she really got almost a second-degree burn from the sun. So she goes to a physician out there in Hawaii who starts her on a Medrol dose pack, which is a steroid taper dose. She starts at the highest dose, and you work downward with time. And I received a subsequent number of phone calls at 2 and 3 o'clock in the morning with my mother, who I could not tell her. I couldn't even break into the conversation to tell her, please hand the phone to my father so he can hang up, because it's the middle of the night here. I don't want to discuss every little nuance of your Hawaii vacation. So that's an example of my mother, but any of our clients can also have that happen to them, whether they are taking that steroid orally, maybe for pain use or because they've got inflammation. We also think to ourselves about steroid use for those with asthma. So, it could be for a variety of reasons, and we want to watch out for that. Now, when we look at the depressive phase of bipolar disease, this looks like somebody who's got major depressive disorder. It has to occur for every day during a 2-week period of time. And here's some of the symptoms. Not only that depressed mood, but markedly diminished interest in what things that normally cause pleasure. One of my clients one time was very much into train sets, and in his room, he had a train track set up and lots of trains. And over time, he didn't want to work with his trains any longer. It was a direct care staff member who said, you know what, we need to look at this individual because he is showing signs and symptoms of depression. As it turned out, he actually did have a diagnosis of bipolar disease. He had the depressive phase first, so they almost diagnosed him with unipolar depression. But luckily, they held on, and that manic phase came, and he was correctly diagnosed. Maybe significant changes in weight or appetite. These are people who may lose weight, may not be interested in eating any longer, or insomnia, or even hypersomnia. So too much sleeping, too little sleeping, fatigue, loss of energy, feeling like you're worthless or feeling guilty over something, or the decreased ability to think or concentrate. So one of the things that we say with both depression and the depressive phase of bipolar disease is you actually can lose IQ points if you don't get treated. So that lack of concentration, lack of being able to make decisions, lack of things like even, is it the time for me to get dressed in the morning? Do I need to go to breakfast? What do I need to do? That all seems so difficult for them to manage. And then, yes, not in all people, but there may be recurrent thoughts of death or thoughts of suicide. Again, the symptoms really have to have a marked impairment in their social functioning or occupational functioning. And again, just like we saw before, they shouldn't be linked to substance abuse or attributed to other typical bereavement patterns. Our individuals are living longer. They may come across roommates that die or staff that are no longer there. They may come across parents or family members who don't visit as much any longer because it may be difficult for them, or parents who die off. That's a normal depressive phase that they're going through. That does not mean that they have major depressive disorder or bipolar disorder. So what's the treatment goals? We want to decrease the number of episodes, the briefest. We want to make them brief and mildest episodes. And then one of the ways that we look at that is we treat the acute depression and the acute mania first, and then we prevent the depressive reoccurrence and the manic reoccurrence. In order to look at this disease state, because we're dealing with both depression and mania, and we're dealing with perhaps mood dysregulation, monotherapy or one drug is probably not effective for every therapeutic objective. So we're going to look at multiple drugs used to treat this disease. Our consensus practice guidelines say to us that the acute treatment of those episodes needs to come first. And the very first thing we do is select a mood stabilizer. This is where I see sometimes we have missteps because we look at our individuals and may not choose a strong mood stabilizer for them, add an appropriate dosage so they can actually be mood stabilized. And we're going to talk about that in a moment. Then we want to look at adjunctive treatments for the psychotic episodes, treatment for agitation, maybe treatments for insomnia. And then how do we manage if they have an inadequate response to the first treatment? What are our alternatives? And then we do the same thing for the acute treatment of bipolar depression. We select that overall strategy, we select specific medications, and then we select backup medications in case our first medications are not effective. So again, the medication classes that we may be using, and as I mentioned, we may have multiple therapies. First and foremost is our mood stabilizers. Those are our anticonvulsant medications that have an FDA indication for mood stabilization. We can also add antidepressants. We can add antipsychotics, and then also adjunctive treatments to the therapy as well. So when we look at mood stabilizers, we have what we call an older medication, old one, yes, developed in the 1950s. So before some of you out there were even born, this drug was on the market. It is still on the market. So in the 1950s to the 1970s, we used a lot of lithium. It was really one of the drugs that was available then. Our mood stabilizers or our anticonvulsants were really developed in the late 1970s, some of them before that, but most of them in the late 1970s and on. So this was the drug of choice because, quite honestly, it was really one of the only mood stabilizers available. Now, it does alter the distribution and exchange of ions involved in the process of conduction of the electrical impulses in our brain. So in our brain, and I showed you a picture of it, and I said, these are our neurons in our brain. Our brain can communicate in two ways, electrically, and of course, you're very familiar with that for our clients. That's what sets them up for seizures, for instance, and chemically. And I just described to you some of the chemicals that are being utilized in monitoring the way we feel on a daily basis, keeping us even-keeled, keeping us stabilized for our mood. Lithium is one of those drugs that also works in that area. Now, the unfortunate part with lithium is that it is toxic, especially when somebody has low sodium. So one of the things I'm going to ask you to remember is lithium and sodium levels need to be very much monitored. So that's one thing. We also monitor lithium levels, and I'll tell you why in a moment. But lithium is a salt, so it's combined of lithium plus chloride or lithium plus carbonate. Why do we like this drug? Because it's non-sedating, which is great for our individuals. They're up and active. We want non-sedating drugs. It also has prophylactic properties, so it helps prevent the continuation of our manic or depressive stages, and it's very inexpensive. So lots of good properties. Now, when we look at drugs and we analyze the appropriateness of a drug for one of our consumers, we want to look at least a couple of things. The first one is efficacy. Does the drug work for what we intend it to work for? Is it indicated for that disease state? And so we can answer yes for lithium. The second thing we look at is what is the potential side effects? And we have to weigh that effectiveness versus the side effects. And I want to take you through now some of the challenging aspects of this drug lithium in terms of potential side effects. So I mentioned to you that we do blood levels, and we do. So therapeutic levels are somewhere between 0.6 milliequivalents per liter and 1.5. So the easiest way to remember it is it's about 1. And the equivalent of that is 300 milligram tablets of lithium or capsules of lithium, which is a common dosage. So lithium, 300 milligrams 3 times a day. Even at therapeutic levels, somebody can develop fine hand tremor, excessive thirst, nausea, and excessive sweating. So think to yourself again, when I'm saying to you, your sodium levels need to be in line, and what can happen if somebody overdrinks and it's actually water toxicity, or if somebody excessively sweats and loses water, or if they're nauseated and throw up, and because of that, they are losing sodium as well as the water balance. So even at therapeutic levels, this is a medication that can have some challenges to manage. Now, some of the toxic signs are diarrhea, vomiting, drowsiness, confusion, and muscle weakness. So again, if you look at those toxic signs, that sounds like a lot of things. It almost sounds like somebody has the flu. I know many of you out there have had flu going around in your families, yourself, those that you care for are consumers. So that's what it looks like. At a level of 2, so that's not too much above that 1.5 milliequivalent per liter. So at 2 or above, difficulty walking down a hall, ataxia, tinnitus, kidney dysfunction. And then a level of 3, which is twice the therapeutic level, coma, respiratory depression, and death. For that reason, lithium is known as a narrow therapeutic index drug, meaning the therapeutic dose is very close to the toxic dose. So yes, we monitor blood levels with this particular medication. We monitor sodium levels, we monitor blood levels. The half-life is about 24 hours, so it stays in the system. And there are a couple of slow-release products which, by their manufacturer, whenever you can utilize a slow-release product, you automatically have a superior clinical product because you don't get those high highs and low lows. So something like Lithobid may be an alternative, may have potential for less side effects, because as the blood level goes up, as we reach the peak, that's where our dose-related side effects are the highest. So if we can basically have a smoother level and not have those high peaks, we may avoid some of those side effects. So classic mood stabilizers like lithium carbonate may be effective for true bipolar 1, but also could be helpful as an adjunct to the other bipolar diagnoses. But we do need to monitor it. So we monitor our levels, we monitor kidney function with BUN and creatinine clearance, we monitor thyroid function and free T4. We do have a concern for toxicity and kidney drug interactions. So this is where you want to avoid NSAIDs. You want to be very careful with our diuretics as well. So the need to consider med selection for somebody who's got hypertension, for instance, or pain issues, that's going to be something that really is something that we want to monitor along with lithium. So we have to look holistically at our individuals. Moving on to the second of the 4 FDA-approved drugs used for mood stabilization, we come to divalproate. And divalproate is Depakote. I'm sure almost everybody out there has heard of that drug. It's been a long, it was FDA approved in 1978. For those of you who like the little history as part of your webinar, I will tell you this drug came out 1 year after I graduated from pharmacy school. It's very effective for mood stabilization, both for the manic phase and the depressive phase. It's also very good for aggression. So anybody who's got bipolar disease or intermittent explosive disorder or aggressive tendencies, this would be a drug for you. It has less medication interactions than Tegretol or carbamazepine. We do need to monitor liver function and platelet counts, and I have in there, especially in the elderly. So who's our elderly these days? When I first started in this field, I will tell you that normal age limit for most of our clients was somewhere in their 20s. Today, if you were to ask around, you find clients who are in their 70s and their 80s. And now we add typically about 10 years on to their chronological age, and that's their medical age. So now we got some folks who are elderly. So we want to watch some of that with our individuals. We want to watch their kidney function. We want to watch their liver function. We want to watch their platelet counts. Now, here's an important part, and that is that for true mood stabilization, and I'm not talking about using Depakote as an anticonvulsant. I'm talking about using it for a mood stabilizing effect and to control impulsivity and aggression and really get mood stabilization. We need to increase the dose of Depakote to the point where the person's blood level is not hanging out around 37 or 48 or 56, but actually much further up to between 100 and 150 micrograms per mil. Now that's a hefty dose. That may be Depakote 4 grams per day. So we want to consider that for mood stabilization and try and get there. You know, it may be slowly that we get there, but get there, recognizing that they may experience some side effects and gait disturbance at these higher dosages. So those medications, we look at 2 things in terms of side effects. We look at dose-related side effects, like gait disturbance or tremor, and we look at idiosyncratic side effects. For Depakote, that may be hair brittleness, and they may start looking like they're losing their hair. So at higher dosages, their dose-related side effects may be more abundant. Carbamazepine is the third drug we're going to talk about. It's also highly effective for aggression and agitation, a little less so for mood stabilization. So it's not indicated as effective as Depakote is, but it's an alternative choice. Now, one of the things about carbamazepine is it's what we call an inducer of our hepatic enzyme. So what the heck does that mean? Well, our liver metabolizes all of our drugs out there, and we have enzymes in our liver, which we can theoretically speed up or slow down. If we speed up some of those enzymes, they will metabolize drugs faster. Not only the drugs like carbamazepine, which is on board, but every other drug that our individuals take. So the average number of medications for our individuals is somewhere between 12 and 14. Is carbamazepine going to affect those drugs as well? Yes, they can. So they can really cause havoc with the blood levels of other drugs. So your Lipitor 20 milligrams may actually be effectively Lipitor 10 milligrams because it's metabolized so quickly. So that's one of the things. Doesn't necessarily mean that carbamazepine is not effective. It just means it's a little bit tougher to work with. We also need to monitor for liver function and CBC for bone marrow suppression. That is one of the boxed warnings that we have for carbamazepine as well. And like Depakote, our optimal treatment may be at higher dosages, more at a level of 10 to 12, where the average level for seizure control may be up to 10. Here we want to go at least 10 to 12. The last one as a mood stabilizer that is FDA approved is Lamictal, and that's lamotrigine. Now, lamotrigine, I will say, is really reserved for a situation in which you want to add it to the therapy or you want to switch to this therapy. Probably not your first choice, and it's not your first choice because it's highly affected by the use of other anti-epileptic drugs, as well as the fact that it takes a long time to get on board. And in fact, we can titrate it over months. Whereas with Depakote and carbamazepine, it may be a month before you get to an appropriate dose. Here, it can be several months. And if we have any of those other enzyme inducers, which are Tegretol, phenobarbital, or Dilantin on board, we want to start very small. So even 25 milligrams every other day. Now, it does have a lot of also active metabolites, so it stays in the system for a while. But it does come in a variety of dosage forms, as you can see there. Even 2.5 or 25 milligram chewable tablets, small doses of 25 milligrams all the way up to 200 milligram tablets. The maintenance dose, if somebody is on Depakote, is 100 to 150 milligrams a day. Otherwise, 300 milligrams to 500 milligrams per day, dosed twice a day, is the optimal dosage. And if you're starting here at 25 milligrams, you can see that it's going to take you a while to get up to 500 milligrams a day. Now, half-life plays a role. Half-life is the time it takes for half of the drug to be eliminated from your body. Half-life is important to us because that's when we dose our drugs. So if the half-life of a drug is 8 hours, we dose that drug 3 times a day. So here the half-life is variable depending on what else is on board, whether we're giving it by itself, or we're giving it with other inducers, or we're giving it with valproic acid. So half-life can change depending on what we have on board as well. And so that is something about Lamictal or lamotrigine that also gets to be a little bit challenging. The other thing is that it may take 3 to 15 days to actually reach steady state. And the side effects are typical side effects that you might find with the central nervous system, which is drowsiness, double vision, dizziness, difficulty walking or ambulating. The one that we used to see much more than we see now is what is called the Lamictal rash. And that was really Stevens-Johnson syndrome type of rash, if any of you out there have heard of that. That is a very severe rash. I actually saw a young child, a 14-year-old boy in one of our pediatric skilled facilities here in Illinois, and he had all of his skin sloughed off so that you could see the musculature. You could see, I mean, he was just bleeding from every aspect. And so that is an emergency situation. Get that person to the emergency room. That typically happens because we start Lamictal too fast, or we go too high on the dosage. Now, that's a well-known side effect, so we're much better at it. But anytime you've got somebody on Lamictal, you want to be aware of that. And then Lamictal, we've talked about this before, has a lot of drug interactions. So our second class of drugs that we may look at after somebody is very well mood stabilized is, do we need to add an antidepressant? If we do, we've got a couple of classes that we can use. Now, antidepressant medications, we might have multiple antidepressant medications on board. So it may be, this is one drug class in which we may use 2 antidepressants. We never use an antidepressant in the same class as the previous one. So our older antidepressant medications are our tricyclic antidepressants. That's just based on their chemical structure. That's what tricyclic means. They do work on norepinephrine and serotonin, and they work also with other chemicals in our brain, and they're called they're antagonists of certain receptors: the muscarinic receptor, histaminic receptor, alpha adrenergic receptor. A muscarinic receptor makes everything in our body dry, so dry mouth. That's our anticholinergic receptor. Urinary retention, constipation. Histamine can cause sedation and weight gain. And then alpha adrenergic, that's found in our heart, so that may affect our heart ability, so that we may have cardiac side effects. For those reasons, and also for the reason that if somebody takes more than they should be taking of the tricyclic antidepressants, they can actually go into a coma and death. So we want to avoid tricyclics probably for most of our individuals and start immediately on the more popular drugs, which are the selective serotonin reuptake inhibitors. And I'm sure many of you out there have heard of Zoloft or Prozac, Paxil, Celexa, Lexapro. So those are the drugs that we would probably start with. We could also work selectively on serotonin. And then also the SNRIs, which work on serotonin and norepinephrine. And then drugs that also work on norepinephrine, but not, or serotonin, but not by a reuptake mechanism of action. And then even drugs that work by working on, for instance, NDRIs, norepinephrine and dopamine, not serotonin, something like Wellbutrin, which is why Wellbutrin may be added to an SSRI, because now we're now covering all 3 of the receptors that are responsible for depression. So depression really is defined as low levels of serotonin, norepinephrine, and or dopamine. And you can have multiple low levels. So we need to build up those levels by contributing to the ability of our brains to utilize what of those chemicals that we have. So that covers all 3. So really our optimal antidepressant selection should be based on some of the clinical effects that we see and avoid some of the problematic side effects. Some patients who are more sensitive to side effects may choose other drugs that seem to be easier for them to use. And you want to consider the overall side effects of not only the antidepressants that you're adding to, but that individual patient and the individual, their history, their presentation. In terms of anxiolytic medications, we try and stay away for the most part with any of these drugs that are anti-anxiety drugs. We use our antidepressant medications in higher dosages to treat anxiety. But here we sometimes, for a short period of time, so shortest duration possible, we use a class of drugs called our benzodiazepines. Those are anxiety relieving drugs. They don't cure the anxiety, they simply cover it up. So again, that may not be the best choice because the antidepressants actually can work on the symptom relief, but here they really calm the person down. Another class of drugs that we can use is our antipsychotics, and they are divided into our conventional, our older agents, versus our newer atypical agents. So back in the 1950s and 1960s, we developed drugs that really work by blocking dopamine. Why did we do that? Because individuals that have psychosis or psychotic features have higher than normal levels of dopamine in the brain, which means that they may see things that aren't there, hear voices that aren't there. We block that dopamine and bring down those levels. And our strong dopamine blockers were examples like Haldol or Mellaril or Thorazine. In the 1980s, we learned about depression. So now we added serotonin receptors to the dopamine blocking ability. And we now cover both our positive signs and symptoms, things that are added onto our personality that shouldn't be there, like seeing things, hearing voices, and then the negative symptoms, which are the flat affect, or maybe not wanting to dress or get up and shower, go to activities. So examples there you're going to recognize as well. That's Clozaril, Risperdal, Zyprexa, Seroquel, Geodon, and Abilify. So we've got many more than that. These are our atypical antipsychotic medications approved for bipolar mania. So 4 of them we've just spoken about. And in addition, we have Latuda and Vraylar. So we use these medications as adjunctive treatment if they show signs and symptoms. And of course, the physician or the prescriber has a choice of medications, and based on that individual, if they have psychotic symptoms, may add one of these drugs. Okay, so now, pardon me, let's say that we've got our individuals stabilized. One of the things that we want to do is have a continuation phase of our mania. So we continue the successful acute therapies at the full dose. We still maintain the effective serum levels. For instance, if we're using lithium, we allow the individual to tolerate their medication. It is really dependent on the prior duration of the manic phase. But as you can see here, the average manic phase lasts 19 weeks. So it may be months before we really are out of that manic phase. If we can arrest it earlier in life and arrest it with the appropriate therapy, this average mania can decrease. Maintenance phase in terms of general principles is to continue the treatments that have worked acutely. And if they have a significant history of depression, we may consider adding lithium or an antidepressant as a second-line option. We want to taper their antipsychotic medications if at all possible. So we don't want to leave them on the antipsychotic for the rest of their life if we can get them over that psychotic feature. If we need to, certainly we would want to continue. If we do need to continue, we would choose the atypical antipsychotics over our conventional agents. Significance of relapse is real. So relapse of bipolar disorder can be delayed as much as possible. That's our goal. And relapse really can lead to that increased risk of suicide and significantly increased healthcare costs, because that may mean hospitalizations. It may be a treatment in a behavioral therapy ward of some sort. So we want to avoid those relapses as much as possible. How do we do that? We maximize the standard mood stabilizers, including combinations if we need them. We add our anxiolytics if we need to for a short period of time. We add hypnotics if we need to, so medications to help them sleep for a short period of time if we need to. We add our atypical neuroleptics, and then absolutely our novel anticonvulsants, those 3 anticonvulsants that I mentioned, as well as lithium, as mood stabilizers, and the others as adjunctive therapy. We want to make sure that we have brief, acute, intermittent antidepressant therapy, because we don't want to throw them into mania. And we address their psychoeducational needs. So really, bipolar disease is multifaceted. It's a disease with a number of treatment phases. We have to consider how we treat first to get them under control. What is more pressing? We are always on the outlook for situations in which that individual may feel that suicide is a way out. We want to avoid that as much as possible. We want to get them stabilized as quickly as we can. We want to choose appropriate medications for them as an individual, not look at a standard protocol of this is how we treat bipolar disease. because everybody is different. Everybody is on their unique mix of medications. And really the regimen simplification that can lead to the most successful treatment is what we want for our individuals. Now, the maintenance phase begins with 8 weeks of sustained recovery, and you continue to maintain those prophylactic therapies during that 8 weeks. Then we gradually taper the acute treatments if possible. We monitor clinically, we follow up maybe monthly in terms of lab levels. We continue that for even up to a year. We're alert for symptoms that look like they may be going into either the manic phase or the depressive phase again. And we educate in terms of lifestyle and self-care. Now, we all hear from time to time about how important self-care is. We all know about the balance in our lifestyle, especially important for somebody who's got this disease state, because this is where they need consistent routines. Sleep is very important, and that 7 to 8 hours of sleep is something that is a goal. Meals on a consistent basis, physical activity, things that relieve their stress. Can we teach them relaxation techniques? Can we learn time management techniques? Can we work with hobbies, things that our individuals enjoy doing? We monitor and track their mood and look for triggers. So what sets them up? Do they have a roommate that keeps them up at night because of some other reason? That's a trigger for somebody with bipolar disease. Do they have certain meals that they don't like, and so they refrain from eating healthy meals? That's a trigger. Are they just sitting around and they don't have that desire for physical activity? We almost have to say to them, let's get up and do something that you enjoy doing. We want supportive relationships. They need connections, just like the rest of us do. They may need therapy. And in fact, the best treatment is a combination of both therapy and medications. We also want to avoid any risk factors, putting them in situations, substance abuse, overspending, impulsivity. Want to make sure that they're taking their medications, they're adhering to them. You discuss the side effects with the clinician. Are there things that we can manage with their side effects? How can we do that? If something is highly sedating, can we give the majority of that drug at bedtime? Focus on nutrition and the importance of a balanced diet. Avoiding sugars, which seems to also be stressful, both in terms of our individuals' blood levels of sugar can put them more into a manic phase. We look for omega-3s, a good diet. I know that's hard in some of our group homes, but as much as possible, we need to make sure that they have that balanced diet. And then a plan for what we're going to do in terms of crisis management. A lot of our states do have a crisis management team, somebody who can be called for an emergency contacts, but we also want to consider trying what we can do in the facilities themselves and avoid a hospitalization if possible. Now, if hospitalization is necessary, we look to the reasons why it might be. Somebody with severe mania or severe depression in which they're showing extreme agitation, impulsivity, or recklessness, severe depression, persistent insomnia, or psychotic reactions that are occurring that you don't feel you can manage on your own in the facility. If somebody is having suicidal thoughts, if they're a risk to themselves or to others, they have aggressive or violent behavior, or they have an inability to function in a safe manner, if they're running out into the streets, if they're putting themselves in danger. We look, sometimes even hospitalizing them for medication stabilization, the need for close monitoring for side effects, and the close monitoring for efficacy. If one mood stabilizer at an appropriate dose is not doing the trick, do we need to add to that mood stabilizer? Do we need to add an additional one? Do we need to add other therapies? Intensive inpatient hospitalization may be needed. Of course, the goal is to stabilize those acute symptoms in a safe environment. And that may be by that 24/7 monitoring or crisis intervention and monitoring. Definitely medication management, adjustment if needed. And then individual and group therapies are probably needed as well. So those intensive treatments can be varied. It can be partial hospitalization or intensive outpatient programs, residential treatment centers, other medication treatment, even ECT treatment for resistant depression or severe mania, or even catatonia. I did have a client in catatonia, and they did use ECT treatment, and they got her out of that. You may have heard of a new medication on the market, relatively new. It's been around for a while, but now used for the treatment of treatment-resistant depression, and that's ketamine. That's administered IV, but it's very, very quickly acting. So even those with severe depression, within a couple of days, you may get them out of that. So that's something that is an intensive modality that we may have to resort to. And then long-term management, we really want to focus on preventing the relapses. We want to keep those therapies that do work so that they do have a good, improved quality of life. You might have to make some lifestyle adjustments, making sure that they're in bed at the same time every night. Again, that the therapy in terms of their diet, etc. Going to therapy, whether that's singular therapy or group therapy. Regular medication checks, working with the clinician. They seem to be doing well on this, or you know what, we're not quite there yet. So just because that clinician starts them on a medication, we still need to routinely check with them. How are they doing in a month, in 2 months, in 3 months? And then to have that strong support system is really important as well. So I'm going to stop here and open it up for anybody who's got any questions or comments.
So we do have about 8 or 9 minutes if anyone wants to put a question in the chat or unmute yourself. We will be sending a copy of this presentation out afterwards to all attendees, and we can certainly include Nanette's contact information if you have something specific.
Yeah, thank you, Dina. And yes, I am available. So, you know, sometimes people don't think of a question, of course, until they get off the webinar.
Right.
So you will have my contact information, and I'd be happy to answer any questions you might have that way. So please feel free to either put it in the chat and have it answered now or at a later date.
Maybe everyone is still just soaking in all the information.
It's a lot. You know,
And-
bipolar disease is not an easy disease state to manage, and it is a lot. And, you know, I talked at a level that I hope was understandable, but these are complicated therapies and complicated medications that we're using.
We did have one question. Is there a difference between disorder and disease, or are they interchangeable?
They're interchangeable. So it really encompasses the fact that there's several symptoms. So, you know, when we talk about, you know, diabetes, for instance, we may have high blood sugar as a symptom of that disease. Here, you've got a couple of things going on, so we call it a disorder, but you can call it a disease as well. It's a lifelong disease.
What about, another question is, are there a shot available for bipolar persons that do not take their medications appropriately? Okay,
So yes, you know, unfortunately, we don't have, for mood stabilizers, we don't have injectables available. So that's one that we would have to work with, although there are sprinkle formulations, for instance, for Depakote. So you can sprinkle that in pudding or applesauce. That may make it a little bit easier to use. For any of our antipsychotics, several of them have injectable formulations. So that's good. Some of the formulations are even long acting. So we do have some clients who might be on one medication injection every 3 months. And that's really for their safety because they are not good at taking oral medications. So that's an alternative as well. For our antidepressants, they are oral medications as well. Some of them probably can be crushed and again put in pudding or, you know, in applesauce. And then our anti-anxiety medications, again, short period of time, you can crush those as well.
Great. Well, we certainly appreciate you taking time to educate us all. And like I said, we will be sending out a copy of the presentation to all attendees.
And Dina, if I may, my name is Chris Asaro. I'm the regional director for Tarrytown Pharmacy I want to thank Nanette for doing just an absolute phenomenal job on today's educational program, and also like to thank giving us the opportunity to host this. I just want to give a quick bit of information about Tarrytown Pharmacy. We actually started only in the IDD and behavioral health segment of the industry back in 2007. That is all we service in terms of pharmacy services, just the IDD and behavioral health segments of the healthcare industry. We are currently in 30 states, servicing roughly 30,000 individuals across those 30 states, utilizing 12 pharmacies, Florida being one of those. We have a great relationship with the ARC. We are both a national as well as a local sponsor for the ARC, so love to have them as a partner. Basically, our pharmacy is very unique, and aside from the fact that we only service IDD and behavioral health, but our service model, we have basically taken and turned it on its head with regards to what you're currently used to in way of pharmacy services. Because we only service IDD and behavioral health, we're very specific to that. And I'll just I can't even scratch the surface on what we're all about here, but we do operate on a calendar cycle, which is different from a regular cycle fill, monthly cycle fill, where we cycle 93% of all your medications. A perfect example of the second kind of a pillar of what we're all about is the educational piece. And you had a perfect example of what we're all about in terms of how we provide education. Folks like Nanette, who are extremely talented, other folks on our team, nurses and other former ICF directors and nurses as well. We're part of the DDNA, which is a national association, nurses association. We hold officer seats on that association. So again, we're completely dedicated to the IDD health segment of the industry. We believe, due to the complexity of the industry, that it really deserves a pharmacy of its own. So that's why we've gotten so specific and so successful in such a short period of time. We have a 96% retention rate since 2007 for our customer base. So we're very proud of that. So I'm going to put my email address in the chat. So if anybody has any questions about today's program, in addition to reaching out to Nanette, or you have any questions related to pharmacy services, I'll be happy to reach out and contact you. Thank you.
Great. Thanks, Chris. And we'll include his email when we send out the copies of the presentation as well. So we are at time. So I thank everyone for joining today, and be on the lookout for the information. Thanks so much.
Bye-bye.
Thank you.